Good day. Our topic for today are the illnesses in the newborn period. The first is your respiratory distress syndrome. It's also termed as hyaline membrane disease. Most often occurs in preterm infants, infants of diabetic mothers, infants born by cesarean birth, or those who, for any reason, have decreased blood perfusion of the lungs, such as occurs with meconium aspiration. The cause of RDS is a low level of or absence of surfactant, the phospholipid that normally lines the alveoli and reduces surface tension to keep the alveoli from collapsing on expiration. 30% of low birth weight infants and as many as 50% of very low birth weight infants are susceptible to this complication. For the assessment of your RDS, after resuscitation, they appear to have periods of hours or day when they are free of symptoms because of initial release of surfactant. During this time, however, subtle signs may appear, such as your low body temperature, nasal flaring, sternal and subcostal retractions, and tachypnea, which is defined as more than 60 respirations per minute. On auscultation, there may be fine ralls and diminished breath sounds because of poor air entry. As the stress increases, an infant may exhibit seesaw respirations or on inspiration, the anterior chest wall retracts and the abdomen protrudes. On expiration, the sternum rises. There is also heart failure, pale gray skin, periods of apnea, bradycardia, and pneumothorax. And your management for your IDS includes your surfactant replacement. The surfactant is sprayed into the lungs by a syringe or catheter through an endotracheal tube. We also give oxygen administration. Oxygen is necessary to maintain and correct your partial oxygen and your pH levels. And we give the patient on ventilator. Now, inspiration is shorter than expiration, so there is an inspiratory respiratory ratio or IE ratio of 1 is to 2. And next would be your transient tachypnea of the newborn or your TTN. So at birth, a newborn may have rapid rate of respirations up to 80 breaths per minute when crying caused by retained lung fluid. So these newborns are often born by cesarean birth in infants whose mother received extensive fluid administration during labor and in preterm infants. Infants born by cesarean birth are probably more prone to develop this form of respiratory distress, and the transient tachypnea of newborn peaks in intensity at approximately 36 hours of life and then begins to fade. Typically, by 72 hours of life, it spontaneously fades as the lung fluid is absorbed and respiratory activity becomes effective. Next will be your meconium aspiration syndrome. So an infant may aspirate meconium either in utero or with the first breath at birth. So meconium can cause severe respiratory distress in three ways. It causes inflammation of bronchioles because it is a foreign substance. It can block small bronchioles by mechanical plugging, and it can cause a decrease in surfactant production through lung trauma. And now for the assessment of your meconium aspiration syndrome, infants with meconium stained amniotic fluid can have difficulty establishing respirations at birth. The Apgar score is up to below. There is tachypnea, retractions, and cyanosis. The infant's respiratory rate may be remain elevated, and coarse bronchial sounds will be heard on auscultation. Now for the therapeutic management, amnio infusion can be used to dilute the amount of meconium in amniotic fluid and reduce the risk of aspiration. Some infants are scheduled to be born by cesarean birth after deeply meconium-stained amniotic fluid becomes evident during labor. And after birth, infants may need to be treated with antibiotic therapy, given with oxygen administration and assisted ventilation, and some infants need to be given with surfactant to increase their lung compliance. Now, what is apnea? So, apnea is a pause in respirations longer than 20 seconds with accompanying bradycardia. So, beginning cyanosis also may be present. Many preterm infants have periods of apnea as a result of fatigue of the maturity of the respiratory mechanisms. They can be also be caused by secondary stresses such as your infection, hyperbilirubinemia, hypoglycemia, or hypothermia. Gently shaking an infant or flicking the sole of the foot often stimulates the baby to breathe again, almost as if the child needed to be reminded to maintain this function. Now, to help prevent episodes of apnea, maintain a neutral environment and use gentle handling to avoid excessive fatigue. Always sanction gently to minimize nasopharyngeal irritation, which can result bradycardia because of vagal stimulation. Theophylline or caffeine, sodium benzoate may be administered to stimulate respirations. And now, what is SIDS? It stands for your sudden infant death syndrome. It is a sudden unexplained death in infancy and tends to occur at a higher rate than usual in infants of adolescent mothers, infants of closely spaced pregnancies, and underweight and preterm infants. Also prone to SIDS are infants with bronchopulmonary dysplasia, twins, Native American infants, Alaskan Native infants, and economically disadvantaged Black infants. Infants of narcotic-dependent mothers are also included. The peak age of incidence is 2 to 4 months of age. Although the cause of SIDS is unknown, there are other possible contributing factors which include the following: viral respiratory or botulism infection, pulmonary edema, brainstem abnormalities, neurotransmitter deficiencies, heart rate abnormalities, distorted familial breathing patterns, decreased arousal responses, possible lack of surfactant in alveoli, and sleeping in a room without moving air currents, wherein the infant rebreathes expired carbon dioxide. And now for your apparent life-threatening event. So some infants have been discovered cyanotic and limp in their beds but have survived after mouth-to-mouth resuscitation by parents. They are most common in preterm infants with a tendency toward apnea or new babies born to a family whose child died from SIDS. Available monitoring of this is your apnea monitoring, wherein alarm sounds when the neonate experiences a period of apnea of 20 seconds or longer or a decreased heart rate below 80 beats per minute. Next will be your periventricular leukomalacia, which is an abnormal formation of the white matter of the brain. It is caused by ischemic episode that interferes with circulation to a portion of the brain. So your PVL occurs most frequently in preterm infants who experience cerebral ischemia. Once the condition has occurred, there is no therapy. So infants may die of the original insult or they may be left with long-term effects such as learning difficulties. And now for your hemolytic disease of the newborn, divided into two. You have your Rh incompatibility and your ABO incompatibility. So first is your Rh incompatibility. So if the mother's blood type is Rh negative and the fetal blood type is Rh positive, which contains the D antigen, the introduction of fetal blood causes sensitization to occur and the woman begins to form antibodies against the D antigen. So most form in the woman's bloodstream in the first 72 hours after birth because there is an active exchange of fetal maternal blood as placental villi loosen and the placenta is delivered. So after this resuscitation, in a second pregnancy, there will be a high level of antibody D circulating in the woman's bloodstream, which will then act to destroy the fetal red blood cells early in the pregnancy if the new fetus is Rh positive. In contrast to your EBO incompatibility, The maternal blood type is O and the fetal blood type is A. It may also occur when the fetus has type B or AB blood. A reaction in an infant with type B blood is often the most serious. Hemolysis can become a problem with the first pregnancy. And now for the assessment in Rh incompatibility, the newborn will have a rising anti-Rh titer or a rising level of antibodies or indirect Coombs test in a woman. Positive direct Coombs test by percutaneous umbilical blood sampling at birth is noted. In this situation, the mother is always Rh negative and the baby will always be Rh positive. So with birth, progressive jaundice usually occurring within the first 24 hours of life will begin, indicating in both Rh and ABO incompatibility that the hemolytic process is at work. The jaundice occurs because as red blood cells are destroyed, indirect bilirubin is released. The therapeutic management of your hemolytic disease of the newborn include your initiation of early feeding, the use of phototherapy, and exchange transfusion. So first, the initiation of early feeding. Bilirubin is removed from the body by being incorporated into feces. Therefore, the sooner the bowel elimination begins, the sooner the bilirubin removal begins. In phototherapy, exposure to light apparently triggers the liver to function in processing bilirubin. So in phototherapy, an infant is continuously exposed to specialized light such as your quartz halogen, cool white daylight, or special blue fluorescent light. The lights are placed 12 to 30 inches above the newborn's bassinet or incubator. And in exchange transfusion, the procedure involves alternately withdrawing small amounts, 2 to 10 ml of the infant's blood, and then replacing it with equal amounts of donor blood. Next will be the hemorrhagic disease of the newborn. It results from deficiency of vitamin K, which is essential for the formation of your prothrombin by the liver. So vitamin K is formed by the action of bacteria in the intestine. Because the intestinal tract of a newborn is sterile at birth, an infant forms minimal amounts of vitamin K until normal intestinal tract flora are established at about 24 hours of age. Infants with the disease have petechia from superficial bleeding into the skin, conjunctival mucous membranes or retinal hemorrhage, and newborn may vomit fresh blood or pass black tarry stools. So in hemorrhagic disease of the newborn, it usually occurs on day 2 to day 5 of life when the available prothrombin is at its lowest level. So the prothrombin time will be prolonged and the coagulation time may be normal or prolonged. So it is prevented by the intramuscular administration of 1 milligram of vitamin K to all newborns immediately after birth. So another disease is your twin-to-twin transfusion. It is a phenomenon that can occur if twins are monozygotic, that is identical and share the same placenta, or if abnormal atrio or arteriovenous shunts occur that direct more blood to one twin than the other. The result of this shift of blood leads to anemia in the donor twin and polycythemia in the receiving twin. The anemic twin may also be SGA because of the lack of nutrients or oxygen for growth. This same SGA twin will be prone to hypoglycemia from lack of glucose stores. The hypovolemic twin will appear pale next to the polycythemic twin. The polycythemic twin is prone to hyperbilirubinemia as the excessive red blood cells level is broken down. And lastly, we have your retinopathy of prematurity. It is an acquired ocular disease that leads to partial or total blindness in children. It is caused by vasoconstriction of immature retinal blood vessels, later known that high concentrations of oxygen as the causative agent and cryosurgery or laser therapy may be effective in preserving sight. Thank you for watching.